Dr. Norvell Coots is President and CEO of Holy Cross Health and President and CEO of the Maryland region of Trinity Health. He retired from the Army as a Brigadier General, and his final assignment was Commanding General, Regional Health Command Europe, and Command Surgeon of the U.S. Army Europe and 7th Army. He's a graduate of the University of Oklahoma College of Medicine, board certified in dermatology, with a master's degree in strategy from the Army War College.
Well, good morning, everyone. I'd like to thank Secretary Walker for the invitation to come. I need to have my slide set brought up. Okay. I was asked to talk about my impressions and experience as a brand new CEO faced for the first time with something like the Maryland's waiver, the experiment that we have. And so I said, well, I was going through a lot of transitions as I did this. It wasn't just to Maryland and the waiver, but it was actually out of the military into the private sector. And so what I'd like to do is to tell you sort of an entertaining story that I hope will sort of illustrate some of the things that have formed my thoughts about the Maryland system and what I think is perhaps the future. I understand that you all are considering perhaps some sort of waiver yourselves, so let me go ahead and begin if I can figure out exactly how to do this. So this is my title, and it's a mouthful, but I said maybe a better title is, yes, you really can teach an old dog new tricks. I'm living the dream. I'm the president and CEO of Holy Cross Health in Silver Spring, Maryland. It's a pretty big organization. I think really our claim to fame is 10,500 births last year. We had 900 births at our hospital last month, and so we're on track to perhaps crest 12,000 this year. So needless to say, we're pretty busy. A very interesting organization, 70 languages spoken, and we are a subsidiary of a larger organization, Trinity Health, which has about 93 other hospital systems within it. We have two beautiful hospitals, one in Silver Spring and one on the campus of Montgomery College, the first hospital in Maryland to be built on a college campus. But my mother would tell you that's not actually my dream. My dream was this, and she kept everything that I ever did in school, so she would know. And in fact, I did live that dream for 36 years. I served in the Army first as a medical service corps officer, got out, went to med school, and came back in. I lived all around the world. More than a third of my career spent in Germany, or in Europe in general. And so I've had the opportunity to come face to face with a lot of other people's health systems and compare them to our own. So that has helped frame my sense of well-being or not with the American healthcare system. I had the opportunity to have a lot of senior level leadership positions in the military, and particularly as Deputy Commanding General of our medical command. I literally helped to run. I was the second in command of all Army medicine worldwide. So a lot of experience in dealing with that and how it intersects with civilian healthcare across the 50 United States. My crowning achievement probably, and what really formed my ability to deal with crises and changes and rapid changes, was as the final commander of Walter Reed Army Medical Center, having taken command right after the great Washington Post scandal in 2007 and closing it in 2011, and merging with National Naval Medical Center to create the joint Walter Reed National Military Medical Center in Bethesda. Plus I got to wear really splitty ceremonial uniforms too, and it was pretty neat. So transition now, I retired on the 1st of August of last year, and I started in my position at Holy Cross on the 1st of August of last year. I followed a legendary 18-year CEO, which is almost unheard of in today's world, but he really set the stage for a lot of the work that was done in Maryland on the waiver, being one of the commissioners in the state. So after a one-day honeymoon, on the 2nd of August, I came face to face with the question, what is it that makes Maryland so special? Well, first of all, is it our flag? Well, hell yeah. I mean, our flag is different from any other flag in the United States. It's a great flag. We love it, but that's not really it. Is it crabs? And I'm like, oh yeah, it's the Maryland blue crab. But you guys are Delaware. You have crabs too. So it's not really that. What is it? It's the waiver. And that is what really makes us unique. Or as some people had warned me when they heard I was going to be a CEO in Maryland, it's the waiver. It's that thing that is going to destroy healthcare as we know it, put every hospital in the state out of business and eventually take control of every private practice and completely change the face of medicine. Well, that's not really true. That's a myth, just as this mythic beast is as well. My healthcare evolution really started as a child. I learned from my father, who was my hero. He was a product of his time. He was one of 3 African American physicians in Tulsa, Oklahoma. And so he was responsible for the health of the community. He had 3 sets of office hours a day, morning, afternoon, and evening, because he said he had to be available for those who needed his care. Because he said the patients that he took care of were the working poor. Twice a week, he did house calls to his elderly and sick and shut in. He rounded on his patients every day in the hospital. I don't know how he did it, but he did. His average office fee was $10 to $25, and when he died in 1974, at age 74, there was more than $100,000 in billables not collected that was outstanding. It takes an awful lot of $10 and $25 office calls to get to $100,000, but he didn't care because he said he would never refuse care to those who needed it. So that charitable aspect and struggling in that fee-for-service environment. I next stepped into socialized medicine, which is the military. Under TRICARE, I could get whatever I wanted, as much as I wanted, whenever I wanted. I just showed my military ID. I walk in. As a dermatologist, while I coded to keep track of what I was doing, the codes didn't mean anything because I got paid the same amount whether I saw 1 patient or 100. And if you came to me and you had 30 different seborrheic keratoses or AKs that needed to be frozen, I would do it. I wouldn't do the first 5 because I got paid for it, the second 5 because I got a little bit more, and tell you to come back in a month or 2 months. I would freeze everything, shave everything, do whatever I could do in a 15 or 20-minute appointment, and then say, I'll see you in 6 months to a year. Because that's what we do. And population health or community health for us was called readiness. Readiness of the soldiers, getting them back as quickly as we could to get them into fighting form so that they could fight and defend the nation if they had to. And the readiness and health of their families, because we recognize that a soldier, sailor, airman, marine will fight better if they know that the health and welfare of their family members is taken care of as well. And that also included our retiree population. So that, to me, is truly the definition of socialized medicine. And then now, full circle, back to community health, charity. At Holy Cross, we do $60 million worth of community benefit, $38 million worth of pure charity, $5 million worth of forgiveness of bad debt. Because we have an obligation to care for those who are poor, and those who are most vulnerable, and those who are in need. And then, of course, we're dealing with what everyone else in the state is dealing with, and that's the waiver. So this is my concept of my transition from my readiness and socialized medicine here on the right-hand side of the screen to what we deal with in terms of the waiver, or my concept of the waiver, on the left-hand side. There are many similarities between the two, and there are some very, very distinct differences, and I'll sort of talk about those later, but really I want to point out the emphasis on quality exists in both. A fixed budget and a global budget are basically the same thing. Your budget is fixed. In the military, we invested a lot in technology to extend our reach and our capabilities to care for that population and keep them as far away from the hospitals as possible, keep them out on the front, on the battlefield fighting, and keep those family members at home. Technology is not the priority under our waiver, unfortunately. So Maryland is an old waiver state, but then a lot of states had waivers back in the 60s and 70s and 80s, and most of the states somehow or another went away from them. Maryland kept theirs, or kept ours, I should say now. And you see sort of the way the system was built. There was still a volume payment, so you could still grow within the health system in the 1970s. Maryland did get more Medicare dollars and does get more Medicare dollars, but actually saves more money for Medicare as well. When fast forward to 2014, the state of Maryland decided while we were doing well, we weren't doing well enough. And we needed to have the first modification of the waiver, or the first new waiver. And here's the Medicare per capita spend that you see. We were number 4 in the nation. But in Delaware, you guys were 10, so in the top 10, we were all busting the average. And so the new waiver was effective in January of 2014 and was designed for a 5-year term. And it really did establish a very hard revenue cap, so it truly fixed the budgets and fix the revenue to a certain rate, and there are different factors that go into it. I was told, they always have saying, hey, if you just do the math. I was told not to try to do the math because the math is fuzzy. There are all kinds of analysts who are paid to do the math when it comes to figuring out the waiver. It was designed to generate over a 5-year period, $300 million in savings. In the first 2 years, this waiver generated $280 million in savings, and we're en route to saving $500 million at the end of that 5-year. We'll talk about the rewards and penalties because there are a lot of them built into the system. And now, a new wrinkle coming into waiver 2.0. By 2017, we had to be able to address how hospitals would take the responsibility for the total cost of care in the state. And we had to choose one of two demonstrations to do, either HCIP or CCIP, which is Hospital Care Improvement Program, or the Community Care Improvement Program, by partnering with community physicians. Much like Delaware, Maryland still has a predominance of small practices, small group practices, and larger groups not affiliated necessarily with the hospital. Of those 1,500 physicians that I have affiliated with my hospital, we actually own only 12, employ 12. I am one of those 12. Everyone else is an affiliate and a partner, so trying to say that we now have responsibility for those physicians and how they practice to keep the total cost of care down puts an extreme burden on the hospital system. When you look at the way we look at the total cost of care in Maryland, you see that almost half of it is in what's considered the unregulated space, the space that the state does not yet really regulate or control. And of that, 1/3 is professional claims and pharma. The state controls inpatient and outpatient services in the hospital setting, and my hospital system is primarily in Montgomery County, but to a smaller degree in PG County, and you see that in our two counties, the state actually controls a little bit less than they do in the rest of the state. There are a number of quality measures built into the waiver, which I think is really good, and that's that emphasis on quality, on total quality of healthcare. And you can see it's quality-based reimbursement. That plus 1% to minus 2%, those are your incentives and those are your penalties that you are assessed every year based on your performance on these different metrics. And where you get into a bit of a trouble is with potentially avoidable utilization. For us, we partner heavily with Kaiser. Kaiser has an entire floor in one of our hospitals and a unit in another, but their data impacts us, and we are having difficulty extracting their data out of our own hospital data. For instance, we are their regional vascular surgery center, and so they send us all of their vascular patients. We got assessed a major penalty for potentially avoidable utilization because the state said we did not know how to properly care for our diabetics, because why were we amputating so many diabetic limbs? Well, in fact, Kaiser sends all of their diabetics to our center to have their vascular surgery or their amputations done. And so it's not us, it's really the way Kaiser runs their system. And we're in discussions right now with the state to talk about how to extract their data out of ours to have a cleaner view of all of our metrics. When you look at the dashboard for Maryland performance, it's green, it's check marks. Maryland is doing exactly what they hoped that the waiver would do. Upping the quality, decreasing the cost, holding down the overall growth of the spend. I mean, it's just incredible what this waiver is doing. Yet, we still are gnashing and grinding our teeth about this. Here are some of the pros. This is just me coming from socialized medicine into the waiver, and I can actually see the pros, so I put them first. Your revenue is fixed. You can actually predict. You know what your budget is. And the beauty of this is, if in certain areas, if you stay below budget, you get to keep the delta between what your actual spend is and what the state is allowing you in terms of it. So that's a good thing. But that is to drive care out of the inpatient sphere back out into the community. Keep people at home, or keep them as close to home as possible, and keep them out of the EDs. So growth is still possible in an unregulated space where you have your clinics, radiation oncology, same-day surgery centers, or if you partner with urgent care centers. I don't have to negotiate with any payer on anything because the rates are fixed. I have to sign contracts, But as I listened to some of my colleagues last week at the AHA talk about having to negotiate for all of these different rates with all these different payers, I said, man, the Maryland system isn't so bad after all, because that's one less headache I have, on a daily basis. It encourages partnership. Well, that's another way of saying if we don't all hang together, we hang separately. We have to realize that we're all under the same waiver, we're all responsible for the same community for the care, so it's best for us to cut down those artificial barriers between us that we call competition and say the reality is that we're partners, because we know that there are patients that go back and forth between all of our different systems. Let's come up with a better way of managing those patients to make sure that nobody falls through the gaps. And we do, in fact, care for everyone across the spectrum. And it encourages focus on the patient experience, and I'll show you that in a minute too. The cons: more volume is bad and growth is bad. You cannot grow in your hospitals. You are fixed. If I am budgeted for 10,000 visits in X and I see 11,000, I have just eaten that additional 1,000, or I get paid pennies on the dollar for that. So it encourages me to be as efficient as possible and stick to that budget that I have. Every time I report to Trinity and they talk about growth, and they're like, why are you down in your ED? You need to grow. I'm like, no, growth is bad. I love the fact that I'm seeing 200 less patients this month in the ED than I saw last month. That is actually a good thing. Lots of stakes and few carrots. There are a lot of penalties. There's a penalty for X, there's a penalty for Y. Last year we were amassed $7.5 million in penalties that they took back out of my fixed budget because I did not meet the targets. Although they also gave me probably about $10 million in revenue and benefits for those metrics that I did meet. And actually, one more thing I wanted to mention. The quality targets are different than the national metrics. So, for instance, in Maryland, the HCAHPS scores are 45%, whereas in the rest of the United States, they're about 25%. So, 5 million of that 8 million in penalties were on our HCAHPS. So that patient experience is extremely, extremely important. And Maryland wants it to be one of the most important things. The patient has to have a good outcome, quality care, and an overall good experience. So, and I'll just give you some closing thoughts. Coming from my life experiences, from socialized medicine into this, the waiver is really not a bad thing. The goals behind the waiver are very good. Population health, taking care of those that are needed. It actually spreads the weight of caring for the uninsured, caring for the poor, the most vulnerable, across all of the healthcare systems. There is a way that it actually does that. And it really does try to push you in the right direction. What it does not do is make it easier for you to really ultimately control the total cost of care because of the system that we have of affiliates as opposed to owned practices. We don't have a lot of ACOs in Maryland and things like that. We have a few. And what it really holds us back on is the use of technology. If you're a well-endowed system like Johns Hopkins, University of Maryland, you have millions of dollars to invest in technology. A system like mine, I don't. If I want to invest in telemedicine, telehealth, it really doesn't do well in reimbursing that or stimulating that, and that's one of the waves of the future in order to do hospital at home and keep people out of the hospital. If I want to increase the capabilities in my own neuro program, which is actually number 3 in the region, it doesn't reimburse me for the use of the newer and newer implants. I get reimbursed at old, antiquated rates. And so if I want to buy the new implants that will help the patients and downstream save a lot of money over time, I have to come up with investment. In my foundation, I've created a $5 million technology fund to help fund that because I'm not going to get that money from the state. And all the money that the state saves, they do not reinvest in the hospitals. They do other things with it. So $500 million in medical savings is not poured back into the state's medical systems. So perhaps that is a drawback. So if you do negotiate a waiver, make sure that isn't part of it. So my 3 parting thoughts. With the emphasis on the patient experience, we all know that the best thing to do is senior leader rounding. Leader rounding of all types. that constant interface with our colleagues, our staff, our patients is very, very important. Around the world, there are people who do that at the risk of their own lives, wearing body armor and carrying big guns into the hospitals. Thankfully, none of us have to do that here. Although I joke that sometimes maybe you have to do it in Chicago, but no one's here from Chicago, right? The second is purely political. You know, if you really want to meet with Russians, there are legal ways to do it. I'm just saying, if you want to ask how, I'm more than happy to tell you how to do it. And the third and final is do not fear quality and cost-saving reforms. Ultimately, it's up to us as healthcare leaders to rein in our own healthcare system, redesign the system, and we're the guys who know how to do it. But if we don't do it, there are people out there waiting to do it. And when I was in the military, we called it our board of directors, and that's the 545 members of Congress. Congress is just waiting to take healthcare dollars and reapportion them to something else, make us the bill payer for other things, because they say we are reckless with our spending, and spending is out of control. How much can a hospital truly control is still left to be seen, but with the Maryland waiver, we're making our best attempts, if possible, to get our fingers into as much as we can and pull that system together to make it very usable. We will never be like the European health system, like Germany's health system or anything like that, which, by the way, really is not as great as people think it is. It's a multi-tiered system. You have a lot of money, you have a lot of care up here. If you don't, you get good care, but you don't necessarily get concierge care. And the Europeans pay 50% or 52% in taxes, and they pay 19 to 22% in sales tax. Not a single American is willing to do either one of those. So we will never have that type of socialized medicine. So before I open for questions, I'll leave you with one picture. This is from World War I at Walter Reed. This is the 100th anniversary of World War I that we're in right now. And not only are we still dealing with the aftermath of World War I in terms of international politics, World War I was a defining moment because it really helped reshape American medicine and medicine in general. Our system of trauma surgery and trauma care, our system of rehabilitation was all impacted by that. And many of the great medical leaders of the 20th century had served in World War I and subsequently World War II. A lot of people don't realize that two of the Mayo brothers were both brigadier generals in the medical corps during World War I. And so just a little bit of homage. And if you notice the picture, there are multiple colors on those patients that are all together. And despite the time, 1916, 1917, 1918, 1919, it just proves that at the end of the day, we're all Americans, and we have a responsibility to care about each other and to care for each other. Thank you all very much. God bless you all.